that up? Can you see that?
Yeah.
You see the slides?
Yes.
We're all good, Jay.
Perfect. Okay, so what we're going to do today, and again, thanks everybody for joining.
Yes.
This is a lot of work to kind of get ready to go through this. What I want to show is and again, just so that everybody knows, I don't know, this is really rolling forward. Sorry, you guys. Let me get back. I don't want to, I'm just the president of the Rhinoplasty Society, and I've been in practice for a long time. And I just note that I went to medical school in Manhattan from 1990 to 1994. And I remember when HIV and AIDS, basically 50% of the population of New York Hospital had AIDS or HIV when I was in medical school. So I have experience in terms of understanding that things have to be very different. And that's sort of the main theme, I think, today is how are they going to be different? I'm not an infectious disease expert, and I'm not a politician, and I'm not a policymaker. And our goal today is not to make policy. Our goal is to discuss options, thoughts, and concepts so that people can have a good idea about how to return safely to practice in their area. A lot of this is locally dependent. Los Angeles is different from Bull, is different from Cleveland, is different from South America. So again, this Rhinoplasty Society is a small group, and I do appreciate everybody jumping on. We had over 1,000 registrants. And I do think that we have some experience with rhinoplasty in our society. So hopefully we can really come to some ideas about how to go forward safely. The world is definitely different. There's no way to eradicate this virus. It's here to stay, and patients want to have surgery. So with that, we must change. Everything has to change, the way that we think and do things in rhinoplasty. And Dr. Sajadian will go through why that is, and same with Dr. Davis. Got to be smart and be informed and know what's happening. I'm going to say it again, it's locally, and understand your patient and your operation. Test your patients, test yourself, and test your staff. These are sort of my general concepts when I'm going into a rhinoplasty operation now. And this is a very key point. I've said it before, I'm going to say it one more time, that your patient has to be an active participant in keeping themselves and your staff safe. They can't just go along for the ride. They have to understand that the world is different too, and that they are part of the solution to making it safer for everyone to have rhinoplasty. There's no right way, and every part of the world is going to be unique, and customization is how we're going to have to see this. And what happens before surgery, the day of surgery, in the theater, and after surgery, all have to be considered long before the patient shows up. And so as people are returning to their practices, what you're going to do to your staff to do in all of these situations are crucial to the safety of the patient and yourself. I think that our PCR is most specific, but we'll talk about the antibody test today. And again, we want to reduce the risk by knowing what's going on with everybody who's in surgery. It doesn't mean somebody's not going to get into the operating room who has COVID-19. It's going to happen. These are the things that I'm doing. We'll go through them very, very much in detail, but I think, again, it's all about testing. I'm going to blow through the rest of these very quickly because we're going to talk a lot about them. And again, I did a podcast with my associate, Millicent Ravello. It's worth listening to because we kind of, this is really good. I guess if you're in Beverly Hills, it's probably very different if you're in Tallahassee, Florida, or Miami for that matter. And we'll hear from Rick Davis about that. But it is useful to listen, and I want everybody to be safe. So with that, those are my opening comments. And I want to unshare my screen here and get, let's get Dr. Sajadian on.
Thank you, Jay.
So you should be able to go ahead, Ali.
Okay, Jay, let me go in here. Okay, thank you, everyone, friends and colleagues. I'd like to quickly share a few ideas about how we can do rhinoplasty safely in the COVID era and some clinical consideration. Let me just time myself so I can stay on time. Are you seeing me? You okay, Jay?
Yeah.
Okay. So this overview of my talk, just a few words about the virus and why as rhinoplasty surgeons we are at higher risk, and some clinical consideration and the strategies for increasing the safety and decreasing risks. As we know, the severe acute respiratory syndrome, COVID-2, is highly contagious and has high morbidity and mortality compared to other coronaviruses. And as of last night, there was 4.4 million confirmed cases and over 300,000 deaths worldwide. And according to CDC, 28 states have reported more than 10,000 cases. And in America, we have 1.9, and in Europe, we have 1.8 million cases according to WHO. So why, as rhinoplasty surgeons, we are at higher risk? There are 4 reasons for that. The sinonasal cavity is a major site of infection by SARS. And to understand why, we look at the structure of the CoV-2, you can see a number of spike protein. And these spike proteins are where the virus uses to attach itself to the host cells. And these receptors on the host cells are called ACE2 receptors. And the virus attaches itself to the respiratory cells in the, and specifically goblet secretory cells that produce mucosa is shown to have 2 proteins that the virus can attach itself to. Jay wanted me to specifically talk about that. So here it is. You can see the respiratory mucosa inside the nose and nasopharynx, which has a high level of spike protein. That's why the virus can propagate there very easily. Second reason is that there is a high level of viral shedding, which appears to be highest at the nose, and therefore it reflects a major source of transmission. In a recent study just published a month ago, it showed that as a clinician, surgeons, healthcare associated infection has happened and does happen with otolaryngology, oral surgeons, and rhinologic surgeons, and now it's considered to be, we are considered to be high risk for transmission. And so that brings up to what Jay was talking about, which is the importance of screening and testing of COVID-19 patients. Additionally, rhinoplasty poses a unique challenge due to the potential for aerosolizing the virus. This is important. So as we know, the virus can survive up to 3 hours and has an estimated half-life of 1 hour in the aerosol. However, on other surfaces can still survive for longer period of time, which brings us to the point of cleaning and disinfection of the environment. And yesterday, WHO put out these guidelines for outpatient and ambulatory care setting. So the question is, for our practical purposes, can we potentially learn from previous studies of the irrigation suction aerosol data, laser data, or dermabrasion data to know what we should do? To look at this, nice study was done by other colleagues in orthopedics, which showed that the irrigation suction procedure during operations was one of major sources of aerosol. Other colleagues from UPenn, rhinology division, with the virus surviving. So my own thoughts, based on talking to a lot of colleagues, is that this is just my own thoughts, not the guideline. To minimize the particulate formation, you should consider looking to see if you should decrease the use of these instruments, such as microsaw, drills, birds, electric grass, shavers, piezoelectric devices, and microdebriders. I also think that I used to use a dual splint in the nose. We should consider not putting intranasal splint to minimize the intranasal debridement in the office after surgery in the post-op period, and instead use quilting sutures. Everything is done to minimize the risk. I know my other colleagues will be talking about strategies to minimize the risk, but as we know, virus is here to stay, and the troubling potential for additional waves of pandemic exists. So I joined these around the world, should get together with some information on safety, potentially by utilizing cone beam CT, which has low radiation until we have better treatment and vaccine available, and also figure out what the role of telemedicine is. Our colleagues in American Academy of Otolaryngology have also come up with some priority lists, and they put in septoplasty, septorhinoplasty in a routine priority. Our colleagues in European Academy of Facial Plastic Surgery, Dr. Saleh et al. Had also come up with some guidelines for healthcare workers that come into contact with patients with COVID-19. You can read this, but this is just if you have come into contact. But as a patient in the operating room, for example, we can use pledgets in the oral pharynx and nasopharynx. You have the patient preoperatively mouthwash with providine, iodine solution agents. In conclusion, it's important to know the nasal pathophysiology and know that it's important site of infection and viral shedding is very high at that level, at that area. And repeated testing and screening are key to prevention, and should come up with solutions with surgical strategies to minimize aerosol formation in OR and in clinics. And we can learn every day about this virus, and should come up with some local and regional epidemiology as a guide to have a focused action on this. I hope this was helpful to you all. Thank you.
Thank you, Ali. I want to get a specific comment from Dr. Gairon and from Dr. Jeffrey Marcus. So Dr. Gairon, from your standpoint, what are the key safety issues knowing that this virus is living in the nose and the pharynx, and with the way that we do rhinoplasty with lots of suction, some use more bovie than others, some even do laser turbinectomies. How are we going to be thinking about this going forward from your standpoint?
Jay, thank you for inviting me. Good afternoon, everybody. Good evening. For those of you who are from Europe, I think this is a very different era. And Jay, you summarize a lot of things very nicely. And we need to think about the stages. First, we need to, and the most important thing is not operating on somebody who has virus and taking a lot of steps to minimize a patient who potentially has the virus to get on our operating room table. From there on, if we take enough precautions, the other changes are not going to be, in my view, as relevant, because we're going to augment the safety of the operation by preventing a patient who has the virus getting on the table. What we do is, first, before the patient goes to the operating room, before the patient comes to the facility, we take a history. We actually have a page questionnaire. Where they have been ever in contact with somebody who potentially had the virus? Have they been tested? And those are the factors that are going to actually isolate the patients. The surgeons and the patients all are monitored for temperature before, again, they enter the facility. And after they enter the facility, we all use masks. The patients use masks until they get to the operating room. And when you think about it, when the mask is on, I think the effect of the mask is grossly underestimated. In fact, had we taken the temperature of the patients, individuals who entered the country, had we advocated use of the mask, we would not probably have been where we are. When somebody has a mask on, is not going to touch the face, is not going to contaminate himself or herself or somebody else so easily. So after the surgery, again, patients get the mask on. The surgeons and the staff all the time are going to have the mask on. So when we adhere to these principles, we're going to greatly reduce the potential for any patient, again, being operated on who was potentially